I'm Renee Shalhas. I am delighted to be here. Once again, whenever Tracy says, will you do something, the answer is yes. So I'm here because Tracy said so. And we have come up with what I think will be a really nice session. There's a little bit of improvisation that's going to happen, and that will include probably not having people up here on this stage because I walk and I'm going to fall off, and I don't want to fall off because that would be bad. And also that there's some stuff as we go, that this is going to be participatory. So if you came here to just like sit back and observe, that's cool, but we are recording. Great. I can walk but they can hear me at least. Okay, good. That's what matters, and we will use the mic for that reason, okay? So we're gonna talk about what is your loved one's precise diagnosis, and we're gonna think about how, LGS, everybody has their own sort of LGS fingerprint, and it's unique, and it's composed of a whole lot of different components, and that's why Elizabeth is giving out these lovely puzzle pieces. Lizzie, can you just wave your hands? If you don't have puzzle pieces, you can wave at her, she'll bring you some, okay? So we're gonna talk about LGS signatures, seizure types, genetic factors, comorbidities, and an acronym that is called DEE-SIGNS, and you're gonna know all about that by the time we finish. So, I don't think we have a formal polling thing set up. We're just gonna do this we do? Okay. I'm gonna ask the question, then it's gonna pop up. All right, so we're gonna start with a question for each of you, which is, LGS is a whole lot of stuff. How clear is your loved one's complete diagnosis to you on a scale of 1 to 5, with 5 being the best and 1 being totally unclear? So there's a QR code up there, if you can scan it with your phone, and answer that question. I like how it orders it so it's not 1 to 5 anymore. That makes it exciting. All right, so nobody is very clear. That's good, because if you had said very clear, I'd say, come on up, I'll give you the mic, and you can do this. And some of you are like, yeah, I know some things, but I clearly feel like I need to know more. So that's really important, so great. Next question. How many different things about your loved one's LGS can you name right now? And that different things is on purpose a bit vague, but that's okay. I can name 3 or 4 things. I can name like 9 things. I can name 6 things. I'll give you another couple of seconds to answer that one. All right, so we can name a lot of different things about LGS, right? So most of you, it went away, but I can still see it up here. Most of you said I can name between 3 and 6 different things about my loved one's LGS. So great, we're gonna name even more, all right? Terrific. First, I'm going to invite Karen to come. Karen is Shane's mom, and you absolutely want to know everything that she has to say, because she has a lot of really great things to say about discovering more and more about Shane. So Karen, I'm going to invite you up and to be wherever you're comfortable to share your story.
Hello, everybody. My name is Karen Mott, and I'm the mom of Shane, right down there. My 11-year-old son, who has Lennox-Gastaut syndrome, my husband, Ray, and I have 3 children, Shane, Reagan, who is 13, going on 21, and Charlotte, who is 5, going on 16. We are grateful to be here in Florida, connecting with other LGS families and enjoying a much-needed family vacation. Today, I'd like to share one important piece of Shane's journey, one piece of his puzzle that helped us better understand who he is and why he faces the challenges he does. That piece is genetic testing. When I was asked to speak about genetic testing and the question, what is my child's precise diagnosis, I thought, wow, it's been a long time since that part of our journey, yet somehow it still feels like yesterday. I can still remember exactly where I was when I finally got our answer, how I felt, and what I did afterward. Honestly, I shut down for a while and just tried to process it all because it was a lot, and it still is. But after the initial shock wore off, I realized two very important things. Knowledge is power, and my kids needed a strong, present mom. If I was going to help my son reach his fullest potential, I needed to understand as much as I could about him and become his strongest support and advocate. Our journey began shortly after Shane was born. Although my pregnancy and delivery were uneventful, I noticed early on that he wasn't meeting developmental milestones. He had significant global developmental delays, poor head control, low muscle tone, strabismus, and as time went on, it became clear that he was not developing speech. Having a typically developing child before Shane, I knew something wasn't right, and I trusted that mother's instinct. At around 5 months old, we went to our first neurology appointment where our first round of genetic testing was done, including Fragile X testing, which is the most common inherited cause of intellectual and developmental disabilities, and a chromosomal microarray analysis, which serves as a first-tier test for identifying many genetic causes of developmental disabilities. When those tests came back normal, we were thankful, but I knew that we still didn't have answers. Our journey wasn't over. Around 8 months of age, Shane began receiving early intervention services. We started with occupational therapy, physical therapy, speech and feeding therapy, special instruction, and later added vision services and ABA therapy. If there was a therapy that could help Shane, I did it, and I still do. I want to give him every opportunity to learn, grow, and reach his fullest potential. At 9 months old, we met with a geneticist who recommended a much larger autism-related genetic panel, and on August 11th, 2016, when Shane was just shy of 16 months old, we finally received the answer we had been searching for from that panel. Shane was diagnosed with a de novo pathogenic variant in the IQ-SEC2 gene. Results were given to us by the geneticist from GeneDx. In simpler terms, this was a spontaneous mutation on an X-linked gene that neither my husband nor I carried or passed on to him. It happened completely by chance in utero. Suddenly, so many pieces of his puzzle fit together: his low muscle tone, global developmental delays, absent speech, autistic features, intellectual disability, and the many challenges we had been witnessing since he was an infant. Although Shane had not yet developed epilepsy at the time of his diagnosis, we later learned that this genetic mutation would also be the underlying cause of the rare epilepsy syndrome that would become a major part of his story, Lennox-Gastaut. Receiving this diagnosis, or any that he has received, hasn't changed who Shane is. It hasn't changed his purpose, his smile, his laugh, or the joy he brings to our family every day. What it changed was our understanding. It gave us answers. Excuse me. It connected us with specialists, research, resources, and other families walking a similar path. Most importantly, it gave us the knowledge we needed to advocate for Shane more effectively and with greater confidence. Although there is currently no gene-specific treatment for IQ-SEC2, there is much hope. Our IQ-SEC2 community has become an incredible source of support, and many are helping move research forward. Through the Facebook support group and foundation, families are raising awareness, fundraising, participating in research, and working alongside clinicians and scientists who are dedicated to better understanding this rare condition. Things are happening, progress is being made, and while there's still much work to do, it is encouraging to know that people around the world are working every day toward better treatments and hopefully one day a cure. For our family, genetic testing became one of the most important pieces of Shane's puzzle. It gave us a precise diagnosis, and with that came knowledge, community, a clear path forward, and hope. If there is one thing I would want you to walk away with today, it is this: never underestimate the value of pursuing answers, especially when it comes to your children. A genetic diagnosis may not change your child. They are exactly who they are meant to be, fearfully and wonderfully made. But it can change your understanding, guide their medical care, open doors to research and support, and empower you to become the best advocate possible for them. Thank you.
Thank you so much, Karen, for sharing that story and for sharing about Shane and your journey. It means a lot. So genetics is one piece of Shane's LGS puzzle. We're going to talk about lots of pieces of the puzzle in the next little bit. And think about how those come together, why it matters to be able to name those puzzle pieces, and what might be some of the pieces that are on that puzzle. So how does having a long list of diagnoses help? This is something that Tracy and I have talked about before of like, gosh, it kind of sometimes feels like a drag. Like every time we turn around, we've got another label, another diagnosis. Is that going to be useful, or does it just drag us down? And I would submit to you that it can be useful because the diagnoses can open a door and get you stuff, right? Get you more support and get you different treatments and the help that hopefully that will be useful to make your life a little bit easier. Name the range of issues that you're facing. Clarify for you, what are your priorities, right? Of all the long list, what are the things that matter right now? And recognize that priorities may change day by day and they may change year by year. You're gonna help to identify what specialists do you need involved in your loved one's care, access new treatments. Bottom line again, diagnoses can get you stuff, but we have to understand what are the categories of diagnoses that we wanna look at. And so we have from the LGS Foundation this acronym called DEE-SIGNS, all right? So this is what we're gonna focus on for the rest of this workshop. And I'm gonna step you through this acronym. Now, if you've got puzzle pieces, we can play with those. If you wanna write down DEE signs on different pieces, and you can take some notes on those if that helps you to organize yourself. If you wanna put it on a piece of paper, that's great, but we're gonna have plenty of time to dig into the handouts that you have and to the content here. So don't worry, just hang on, we'll go along this ride, okay? So DEE signs. I'm gonna step us through what we mean on each of those and a little bit about it, and then we'll take some more time. So the first one is D, right? We've talked about DEE. Let's start with the D, developmental delay or intellectual and developmental disabilities. In general, people with LGS have some degree of developmental delay or intellectual disability, right? That's part of the diagnosis. How do we diagnose that? Well, the most specific would be to do formal neuropsychological or other formal developmental testing, right? That requires a referral, which means you need to know that it's a thing that we're looking for. And I would say, it's really not a side note. It's key to unlocking early intervention, school services, therapies, right? Disability benefits, adult support programs. And we know that developmental challenges may evolve over time, right? So that's the D piece. E is epilepsy, right? That's what often brought us to medical attention in the first place. Epilepsy, all that epilepsy means is a condition with recurrent unprovoked seizures. So unprovoked means it wasn't that you got knocked on the head and then you had a seizure because you got provoked by getting knocked on the head, right? Or an infection or a bleed or those sorts of things. Those are provoked seizures. This is unprovoked seizures. So out of the blue, a person has a seizure. If they have more than one unprovoked seizure, then they have epilepsy. Seizures are treated, as you know, with anti-seizure medicines and sometimes dietary therapies and sometimes surgery. Epilepsy can be classified, and we classify based on whether seizures are focal, meaning they start in one part of the brain and they may or may not spread, whether they're generalized, starting everywhere all at once, or it may be mixed. Some seizures are focal and some seizures are generalized. Why do we care? Different treatments are going to be more effective depending on whether the seizures are focal or generalized in onset or mixed, okay? So we have our epilepsy, that's the first E. Second E is EEG, right? And we talked this morning that there are patterns of EEG that are specific to LGS, right? That slow and disorganized background, a slow spike wave discharges, and generalized paroxysmal fast activity. I'm not going to torture you with an EEG fellowship this afternoon, but just to know that EEG patterns can change over time. And so somebody might not have all of the signs on their EEG of LGS now, but that doesn't mean they didn't have them before. EEG is also really helpful to characterize events and figure out what events are seizures, what are not seizures, what kinds of seizures. And then we also look at the pattern between seizures called the interictal pattern, or the between seizure pattern. So that's the E piece. Has my loved one had an EEG? When was the last time they had one? Have they ever had one when they were actually doing pretty well, or have they only ever had them when they're sick? Those are kinds of questions that we might ask. Then the S for signs. S is seizure types. LGS typically involves multiple seizure types. So based on our diagnosis right now, you have to have tonic seizures or have had a history of tonic seizures, that's stiffening seizures, at some point in your life. But there are lots of other kinds of seizures that people with LGS may have. Seizures can be assessed and classified by video, by EEG, by seizure diaries, lots of different ways. Different seizure types may respond to different treatments, so that's really important, and that's why we want to name those seizure types. We also know that some kinds of seizures cause injury, right? Seizures that cause a person to drop can certainly cause injury. If we know that that happens, that can unlock access to helmets and other things, right? And we know that some kinds of seizures increase the risk of SUDEP. So convulsive seizures that happen during sleep increase the risk of SUDEP. So we want to be able to name the kinds of seizures that we have, how often we're having seizures. I is for intractable. Intractable means treatment resistant. In the epilepsy world, this is defined specifically as persistent seizures even though we tried 2 or more appropriately selected and adequately dosed anti-seizure medicine. So if somebody took a medicine, got a rash on day 2, and they never really tried to know, they're allergic to it, so they can't use it, but that doesn't necessarily automatically mean they have intractable epilepsy, right? But if they took a medicine for a period of time at a decent dose, and it was the right kind of medicine for their seizures, that would count as an adequate trial. So 2 or more trials of medicines, if you're still having seizures, then you have intractable epilepsy. This matters because it gives us access to other medicines. Most of our clinical trials require that somebody has continued seizures despite trying at least 2 medicines, so that's an important piece. Access to dietary therapies, access to surgical treatments. And I would also say, if you really have intractable epilepsy, access to thinking about, do I need an epileptologist rather than simply a neurologist, okay? And then there's genetics, and we're gonna hear a little bit more about genetics, so I'm gonna gloss over this quick, but as we've said many times so far already today, not all people, but many people with LGS have a genetic cause for their epilepsy syndrome. We know that genetic testing has improved a lot, and I said this morning, but if you haven't heard it again, testing that was done 5 years ago or 10 years ago is now out of date. Okay, so if your loved one had testing and you didn't get an answer, but it was a few years ago, it's worth reassessing. Is it time to redo that testing or reevaluate that testing? If you did it 5 years ago and you got an answer, you don't necessarily have to repeat it. But if you didn't get an answer, sometimes that's helpful, all right? Genetic testing results can influence our treatment choices, our long-term planning, eligibility for particular clinical trials, family planning, connection with specific communities. And our N is for non-seizure issues, or comorbidities or coexisting conditions. Comorbidities and coexisting conditions did not fit well into the DEE-SIGNS acronym, so we went with non-seizure issues. Obviously, these often have a very important impact on quality of life for people with LGS and their caregivers. Things like behavior, things like sleep, GI, feeding, constipation, reflux, breathing, right? Aspiration, asthma, mobility. The good news here is there are experts in each of these areas, right? And often, if you can get with the right expert, you can get a treatment that will help. Will it make it all go away? No. But we can do better, right? So if we have a diagnosis, and we may have a long list of diagnoses, that can help us to get to the right people to get what we need. And then there's S for syndrome, putting it all together, right? LGS is a syndrome label. It describes the whole combination of the seizure types, the EEG patterns, the developmental picture, and often is associated with an underlying identifiable cause. Now, say I have a gene. I know that I have a SCN2A, and I have a LGS phenotype. You have both things, right? But it's putting it all together. I have LGS due to a particular gene. We know that epilepsy syndromes can evolve in predictable ways. So we've heard this morning of families where a child first had infantile spasms that then evolved into LGS. That's important because we can sort of think about how do we plan and how might we anticipate the epilepsy evolving. Gene-specific syndromes, like I just said, can include LGS. And with an identifiable syndrome, we can ask for the needed resources, we can look to the future, and we can tailor care, and we can connect with communities. So that's DEE-SIGNS, all right? I'm gonna pause for a second and let you all sort of soak that in for a sec. And I'm gonna invite my colleague up. We're gonna switch over to the other slide deck that is gonna tell us a little bit about more about genetics, and then we're gonna come back and we're gonna be thinking about DEE-SIGNS as an acronym.
Thank you so much, Renee, and thank you, Karen, for being vulnerable and sharing your story with us. My name is Jessica Shiles-Hess. I am a genetic counselor by trade and an advocate by heart, and I have the honor and privilege of speaking with all of you guys today a little bit more about genetic testing, particularly in epilepsy. Fun fact, about 50% of unexplained epilepsies actually have an underlying genetic cause. So I wanted to just take a moment and kind of soak that in, because that means that some families that might be looking for answers, there could be an explanation to the unexplained seizures. And I'm gonna dive a little bit more into the bare bones of genetic testing. So before we dive too far in detail, I'm gonna level set with everybody just about genetics as a whole. We all have DNA. It makes us who we are, right? And within the DNA, it's all housed in our cells. And if you think of your DNA as kind of like a long strand of a genetic code with a bunch of different letters, that code is actually condensed into what we call these structures chromosomes. Chromosomes are what houses all of our genes, which are the instructions that tell our body how to function and how to work and how to grow. And the genes, we actually have over 20,000 genes in our bodies. And to this day, we know that there's over 900 genes that actually are a known cause of epilepsy. So you might be wondering why there's a cookbook on this. As a genetic counselor, we love using analogies. So analogies help break down some complex topics to help better understand and digest the information. So our entire cookbook, you can think of the entirety of your DNA. The cookbook is a recipe to making you who you are, how you function, and how to build things within your body. When we're looking and talking about chromosomes, you can think about the individual chapters. The chapters all have specific topics of parts of the body. And then when we go further down, you're looking at the genes. So within the chapters, there are certain recipes that tell your body to perhaps make a part of your brain, or maybe make a few proteins and or hormones. And so there's a multitude of functions of the bodies. And when it comes down to it, our genes are the building blocks of what makes protein and what makes our bodies truly function, grow, and develop normally. So if you think about that, when we're talking about genetic testing in particular, not every genetic test is created equal. There's been a lot of talks about genetic testing, and I'm gonna give a few examples here related to the analogy that I shared to give you a more in-depth understanding of the types of genetic testing. So if you see here at the very first part underneath the entire cookbook, you have exome or genome sequencing. You've probably heard that thrown around, and exome or genome sequencing is going to be the most comprehensive test Think of it like reading the entire cookbook. It's going to look at all 20,000 of those genes and look for certain spelling mistakes or errors that could predict a condition. When we move over to chromosomes and we look at the individual chapters, oftentimes, and Karen shared that some of her earlier testing was done with chromosomal microarray or CMA. So chromosomal microarray is looking just at missing or additional pieces of the chromosomes themselves. So we're just looking at the chapters, not necessarily the entire genome or exome. And then you go down to your single gene test or your panel testing, which Karen also gave testimony to her having panel testing. Panel testing is going to be looking at specific recipes or genes that are associated with that particular condition. A lot narrower, and when Renee has shared and multiple people have shared that looking at the test after it's been done, science continues to evolve. And so if you look more broadly, there might be a chance that you can find an answer. So the types of results that genetic testing result in are a positive, a negative, or a variant of uncertain significance. A positive is we found a change within your DNA, oftentimes called a variant, that we know has explained and can explain the symptoms at hand. A negative or non-diagnostic result means that there were no changes found with the information that was looked at the time, so keep that in mind. And then we have a variant of uncertain significance. This means that we found a change in the DNA, but we don't know whether or not it causes disease. And so when we talk about reanalysis or looking at information, it can go one of two ways. If you've had narrower testing in the past, it could be worthwhile to evaluate broader testing like exome or genome sequencing. If you've had a result of a variant of uncertain significance, it's always good to check back. The timeline is about 2 years, so to let science evolve, but there might be more evidence that builds to push that variant of uncertain significance one way or the other to determine whether or not it's associated with the symptoms that are being seen. So why is genetic testing important? This has been sprinkled throughout all of your conversations and speakings events that have happened today. So I'm not going to touch too much on the tactical portions of genetic testing. I think that the medical piece is very evident that you can get better access to treatment, surveillance and management, perhaps start or stop medications that might be harmful. And one thing that we have seen and heard, and Karen is a living testimony to this, right, is something that's more deeply and more personal to all of the families that we support, and it's a peace of mind. Going years of uncertainty with not having answers and then finally having answers can truly help and has helped families move forward with greater confidence in their child's care or their self. This is just an example of one of the genetic changes that can be found. SCN1A is associated with Dravet syndrome, and it shows the different treatment options and or avoidance of certain medications because of the genetic factor. So this is just a good example here of just the evolution of precision medicine, specifically in epilepsy, and that continues to evolve every day. So who should get genetic testing? All of you. No, I'm just kidding. But like I said, 50% of people that have unexplained epilepsy, there could be a genetic cause. So it's worth asking the question. So medical professional organizations back exome or genome sequencing as the first tier test to somebody that has unexplained epilepsy. The American Epilepsy Society also endorses this. So the other things that are very important in addition to the unexplained seizures is if there's also conditions such as intellectual disability, developmental delays, or even congenital anomalies that are seen, it absolutely warrants a look at further genetic testing. Oh, and one thing that I wanted to note on this last slide that I don't know how to click back to because I'm afraid that I'm going to mess something up is, thank you, when it comes to genetic testing and who should get genetic testing, a common misconception is that if it doesn't run in my family or nobody else in my family has had any sort of symptoms or epilepsies, why should I get genetic testing? Oftentimes, and I keep referring back to Karen, it's because it's almost like she knew that this is what I was going to talk about, as part of her journey. Shane's diagnosis was a de novo variant, or what we say, a new variant that was found, and it happens by chance. It happens during conception, and it's not inherited from either parent. And as a genetic counselor, you can't often see a family pattern that's tracking down when you have de novo variants. So I just want to kind of call that out as a general misconception that there is still a chance, even if you don't have a family history, that genetic testing still can find answers. So where to get genetic testing? You have a bunch of incredible doctors that have spoken today. Of course, refer to your healthcare team, pediatric neurologist, your epileptologist, ask the questions. Hopefully they can help you. You can also see a geneticist or a genetic counselor. Genetic counselors are trained in molecular genetics and psychology to help you not only understand the genetics behind it, but the emotional journey that comes along with a genetic diagnosis or lack thereof. And then last but not least, if genetic testing is not accessible to you or your family, either through your provider or if you're in an area that doesn't have local access, you can always access it through telehealth. GeneDx has partnered with a handful of telehealth companies to be able to give individuals and caregivers and patients access to testing from the comfort of your home. Is genetic testing, and I forgot to mention this earlier, is a common question that we get. How is it done? Through a blood or a saliva sample. And so with the telehealth, they often will send something home that's just saliva that you can send in your child's sample. And then outside of that, GeneDx, I will say, is not the only genetic testing company out there, but we do offer genetic testing, so whatever your provider goes with or whatever you are comfortable with is going to be the best path and journey for yourself. So these are just the key takeaways. Whole exome or genome sequencing is going to be the most comprehensive genetic test. A significant number of individuals with epilepsy, global developmental delay or intellectual disability, cerebral palsy, and autism, which were also on that list of others who should be tested, who should be seen and evaluated for genetic testing. Those could have an identifiable genetic cause. Testing can be accessed through your healthcare team or telehealth pathways. And last but not least, earlier diagnosis by genetic testing can significantly improve management and patient care. So thank you guys so much for your time.
Thank you, Jessica. I'm going to steal that back. All right, we're going to switch back to our other slide deck. All right, and I'm going to skip forward on this. So we're going to come back and work on DEE-SIGNS in a second. But really importantly is, what does having all this stuff unlock for you? And so I'm going to bring Tracy up to say a little bit about that.
All right, this is my favorite part of this whole session, so I hope you're as excited about it as I am, because I would have loved to have had this back in the day. What does it unlock? Every time we would get another diagnosis, it felt like a punch to the gut, and I'm tired of it. And then we live in a community where it's like, you should only have one. Okay, we don't have one. We have many. And so what? What does it mean? And I'm going to give you two answers. The first of all, it unlocks specific services and supports, each of these DEE-SIGNS. And if you scan this QR code, it will tell you what you get if you have D. It'll tell you what you get if you have E. It'll tell you what you get if you have E, the second E, and on and on. And the second thing is if we are ever going to get to the right treatment right now, we have got to treat across all of these signs. And when you think about non-seizure issues, that's huge. But we can't just be treating seizures. We have got to be thinking about these kids' behavior. We have to be thinking about their gut. We have to be thinking about the rest of their GI system. We have to be thinking about their attention, their alertness. We have to be thinking about all of that. And that is how we're going to get to the best treatment right now, is by doing this. So I wish somebody had pulled me aside and just said, this gets you stuff back in the day, and told me what it got me. So we're gonna pull you guys at the end and see if this is helpful, but I'm nerding out over this, and we hope you guys find this helpful. And on the screen here, you can just see what does it unlock, what you can ask your doctor about, if there's LGS resources, and then other resources that are out there. And our goal is to build out this worksheet because you guys actually know what other supports are out there that we've missed. So I'll hand it back over to Renee, and you guys can work on finding your own loved one's DEE signs.
Right on. All right, I'm going to back up. So we are going to improvise a little bit here, because when we planned this, we planned that there was going to be round tables that would make it really easy to have discussions. It's all right. We improvise. We're an LGS family. We can do hard things, and we can improvise. So here's what we're going to do. I, almost 4 years ago, moved my family from Ann Arbor to St. Louis, and when we did that, we had 2 of our girls move with us, and they had to go to new schools immediately, and we said, you know what, this is an opportunity to meet new people, because every new person you meet is a potential new best friend, PNBF or PNABFA. And now you are sitting in a room of potential new best friends, and you are going to talk to them, all right? So in a minute, I'm going to ask you to be flexible with me. And probably if you're in the front of a group, I'm going to have you just turn your chairs around or move your chair as you need to divide into groups of like 5 or 6, whatever is comfortable in the groups around you. If you need to move, or if you need to sort of cluster around a kiddo who is sitting in the aisle, that's great. But I'm going to have you move into groups of 5 or 6. We're going to give you some Post-it notes, all right? And you're going to have 2 Post-it note colors. I'm looking for a pile of Post-it notes. There were some over here. There's some yellow ones. So okay, so we've got some like pink ones and some blue ones, all right? So we're gonna say, on the blue ones, you're gonna say you take D for developmental delay. I want you to write down 1 or 2 things that like resonate with you about that letter, okay? On the blue ones, it's the things that like, this makes sense to me, okay? On the pink ones are the like, but I have a question, or I have a concern, or this piece doesn't make sense to me, okay? Does that make sense? Blue, yes. Pink, meh. All right? Can I get a couple thumbs up of like, does that make sense? Are we good? Questions? All right. So find yourself groups of 5 or 6 or some comfortable number based on where you are, okay? And we're gonna make sure you have some Post-it notes, blue and pink. And I want you to go through and look at D, and look at E, and look at E, and look at S, look at I, G, N, S. We've got 15 or 20 minutes to do this. And when we're close to time, I'm going to have us collect those up, and there's going to be some papers at the front that we're going to cluster them by the letter so that we can sort of start to get some feedback. Are you good? Make sense? No? Good, I'm glad. All right, here's what we're going to do, all right? Let's say these are my PNABFAs right here. These are my potential new best friends, okay? We're going to take D and the first E, all right? And we're going to get our little Post-its. We're going to have pink and blue, and if we don't, we're going to improvise with what we've got. On one of them, you're going to write the things that, like, this makes sense to me. D is developmental delay, and my loved one has developmental delay, and this is what I get from it, and it's good. And I'm also going to say, but I don't know how to diagnose developmental delay, and I have questions about it. That will be my other note, okay? Once I feel good about D, we're going to do E, all right? And I may come and nudge some of you into the later letters so we don't get stuck, okay? Does that make more sense? Okay. Find your potential new best friends, and we will circulate and try to help you, all right? Go. All right. We have... Yes, we understand the concepts. Check, 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 check. So there's a group back there who knows a lot, and that's great. Developmental disabilities, early identification and funding supports, and knowing what questions to ask. Seizure types, changes in terminology, that's important. We keep changing the names of things, and that's a pain. Just pick something that what you call and develop that with your doctor so that you all know what you're talking about. Information is good. I like that one. I'm going to stick with that one. Information is good. We have a lot of, and because many of you started with the D, so that's probably why we have the most on D, but we have some good ones here of, I don't want a label of a disability and not knowing where or why to go get that D. So this is where what Tracy was talking about, what do we unlock when we have that label? Labels can be really tough, but they can also be empowering, right? G, we have a lot of questions. That's what that one says. Developmental disability, how do we diagnose this testing, and why don't we pay as much attention to adults with developmental disability and intellectual disability? Yeah. Non-seizure issues. We have gut issues. We have pulmonary issues. What's the difference between a syndrome and a disease? Excellent. If we know the risk, what are we doing to prevent it? Yeah, good question. We have some questions about seizures and how do they look? How do they look? What's the difference between focal and generalized seizures? Does my child's medicine match their seizure type appropriately? Do we understand what to look for in non-seizure issues? So lots of really good things that you all have raised here, and we're going to take pictures of these so that we have them and we can bring them back as we work through and try to make this tool as useful as it can be for you. So thank you for contributing those. And if you have more ideas as they come up over the next half hour or so, you're welcome to, if you still got Post-its next to you, write them down. You can put them up here, or you can wave at us and we will come and get them and we'll classify those for you, okay? Our next thing is you should all have a handout that, I'm going to steal this, I promise I'll bring it back. That looks like this. It's like 5-ish pages long. Everybody have something like this? Okay. This is your turn to work on this for your loved one, okay? To work out, what do I know about my loved one's LGS signature right now? Okay? We're going to give you time. I and Tracy and others will circulate around if you have questions that we can help you work through. We're happy to do that, but we're going to give you a good 20 minutes to just kind of dig in and write as much as makes sense for you right now about your child's DEE signs. Make sense? We good? Study hall. Go. I heard a couple of comments as I was walking around about what was helpful in this sort of exercise and what was not so helpful. I heard some people saying, gosh, this is giving me kind of a way to wrap my arms around things. This is highlighting for me areas that I feel like I'm not getting the best care, and that can be very frustrating, and I hear you. I'd really love to hear a little bit more about what is good in this and what maybe isn't resonating, and I got very thick skin. But what I would love also to do is if one of my colleagues could be a mic runner for me, or Miss Elizabeth is going to pop up because, fun fact, that's my daughter. So I can volunteer her. All right, you're going to look for a hand that's up. So I would love to get your feedback. If you're willing to share something that you liked about this DEE-SIGNS construct or the worksheet, something that you think we could make it better, could you wave at me? Anybody? Anybody? Yes.
I think that the content was good. I think it was good information, but like I'm a nurse, I'm already medical, so some of the information I feel like almost like if we could have split it into who's already on the medical side of things. And I think that might have been a little bit more, dive a little differently is my feedback.
Great. So for those who have a clear medical background, maybe we could dive in a little differently than those who don't. Thanks, that's helpful.
I like this exercise. I thought it got you thinking, good questions, and I like the organization of this sheet, and I know I'll go back to it. Just one thing that might help is yeah, a little bit of us pre-grouping ourselves. Like I ended up sitting beside somebody that, you know, probably our kids have a lot in common and similar age, and that's really helpful. And, you know, like that's what you want, right?
Great. So first of all, I'm glad, did you know each other before? Oh, yay. Making new best friends is really important. So that's good, but it's also helpful to hear we'd like to kind of group ourselves by some common theme, which I think is kind of what you're saying as well.
I'm brand new to this community and I loved this worksheet. I thought it was awesome. It was also really overwhelming. But are there really like aha moments that any other parents had? Like how can I get that information?
Tell me your name. Any aha moments that any of you want to share with Christine? LGS Family Facebook group. All right, so the comment there was, I get more information from LGS Facebook group than I do from my doctor. I am not her doctor, thank goodness. It's the little things. Can you say more about give me an example of a little thing? Yeah.
We talk a lot about poop. And that's not something that you're always going to sit there and talk to your epileptologist about. But my friend over here, she probably has had the same issues. She knows that when we need to do a clean out, what a clean out is, and discussing what's the better options for it. My son Dominic, I've never gotten anything that actually works until I went on that Facebook page and looked through it. But the support groups are awesome because you can ask anything, especially if Jen's running it. It's perfect because she'll let you have your time like, hey, what do you need? How can we help you? And that's just what the whole foundation is. And there's all kinds of resources there too, which I think are awesome.
Thank you.
We have a second mic now. I'm the mic runner, and here's a question.
Okay.
It's more just of a comment to the aha moment or my favorite tip to share. The LGS Foundation has a YouTube channel. So all these cameras and recordings of all these conferences from the past at least 4 conferences, maybe more, are all on the YouTube channel. And you can be like, ooh, Scott Perry. I like him. Ooh, that was interesting. Oh, well, look, he talked about this too. Oh, that's really interesting. And so you can, even if you can't be here, it's all there. So every one of them were awake in the middle of the night, just get on YouTube, LGS Foundation, subscribe, and then you'll get notifications when these videos post.
Thank you. You don't have a mic yet. Okay, we're going over here, and then we'll come to you.
Okay, yeah, it was just real quick. It was, this is my second conference, and nothing has been better at these conferences for me and my daughter than breakfast, lunch, and dinner, sitting around a table with other families that know exactly what I'm talking about and asking every question I could possibly ask. And there's still a million more questions I have to ask, but that is the best possible thing. Find a table full of people and sit with them and talk to them.
Great advice.
That is great. That is great. You're right. So I want to say that we heard a lot of things about adult transition, that how difficult it is and so forth. I have not found it to be so. In the very beginning, it was rocky. My son is 40. We're in a great place. We're in a teaching hospital. It's wonderful. We have a great team. We have a huge number of doctors. It's like 32 on his page, but it's great. They communicate. It's working well. It can happen, but Geisinger Medical Center.
They're
So-
about to get a bunch of referrals, that's why I'm asking.
Yeah, it's great. Our epileptologist is wonderful. And the reason I bring that up is because I go into these appointments with new doctors with information about Bill, about him personally, about how the syndrome impacts him. And more importantly, I go in with information about the foundation. And once I get to know the epileptologist, because he was new to us, I said, there were some really great workshops at this conference that if you're interested, I can give you the links. And I did. And he changed the way he worked with several patients as a result. So I don't think we should hesitate to share what we learn with our doctors. So just
Absolutely.
my 2
'Cause we're,
cents.
we're all learning as we go, right? And the state of the art is moving fast. So if you show up, right? Show up with your DEE-SIGNS worksheet. Say, I got this from the LGS Foundation. Your doctor may end up on that website trying to learn too, right? And that is a good thing. Any more comments? Tracy's down there, right here.
So one other thing I shared is that I have felt very lonely in all of this. So Emma is 20 now and didn't have her first seizure till she was 17 and had LGS within months. And so she was a very outlier diagnosis. And they did genetic testing and found a mutation that causes Rett syndrome in most girls. But for her, she doesn't fit in any of the categories. So we've seen 3 different Rett specialists and gotten 3 different answers. And some say that's what's causing it. Some say it's not affecting her at all. So it's just, we just always feel like we don't fit neatly into any categories. And so it makes it lonely at times.
Thank you. Thanks for sharing that. Do we have one last comment or? All right. I have heard a lot of, I feel lonely. I want to make connections. I told you about potential new best friends. So I'm going to try to help make a couple of connections right now, if we can. If you're a medical professional, can you stand up? I see you, Dr. Gupta, Dr. Worrell. All right. Here are some medical professionals, if you need to see them. Go ahead and sit down. If you are a family member who has had 30 years or more of experience with LGS, can you stand up? Right here, right here. How about 20 years? All right, we got 20. How about 10 or more? We go in over here, we got lots of you. 5. We got a few. 3. 0, 1, or 2. We are here for you. I hope you found somebody that you might want to go and talk to. All right? So as we take our break, go make a new friend. Know that you're not alone. And know that if you have more questions about this stuff that we just talked about or anything else, Tracy and I will be up here, and we're happy to talk with you too.
Thank you, Dr. Shellhouse. That was amazing. I have one announcement on the note of loneliness. So we heard you loud and clear in our survey. I'll be talking about this a little bit tomorrow. But this fall for International LGS Awareness Day, we're going to be launching our LGS app, where if you choose the permission in this app that the LGS Foundation controls and can't be scammed by the Zuckerbergs of the world on the data and then trolling us, you can connect with other families. So if you say, I live in Atlanta, Georgia, you will be searchable as someone who lives in Atlanta, Georgia. So we're very excited about that. And then next year, we are going to start having small regional meetings around the US at first, but then North America and then beyond. We're probably going to do 2 to 3 next year, but one of these days we're going to come to your area. I want to go to like, I don't know, like Montana and like Oklahoma and Arkansas and all these places where they don't have an academic medical center nearby. So thank you, everybody. Go enjoy your break and go meet somebody. Dr. Shellhouse, you were amazing. Jess from GeneDx, you were amazing. Thank you very much. We're up if you have questions.
And Karen, thank you.